Thank you, Mary. Good morning, everyone. I'm really happy to introduce Dr. David Gregornik, visiting us today from Children's Minnesota and adjunct at the University of Minnesota. David is definitely the most experienced person in the room in pediatric pharmacogenetics. He's currently the director of pharmacogenetics at Children's Minnesota, and that's where he received his doctorate in pharmacy. He then had postdoctoral training at St. Jude and was there in the early days of their pharmacogenetics program. Subsequently also was at Memorial Sloan Kettering Cancer Center, and then has been in Minneapolis since 2016, has experience as a training program director, members of ethics committees and IRB at the various institutions he's been at, and is really a leader in the field of pediatric pharmacogenetics implementation. And I'm very excited that he's here today to share his wisdom and experience with us. So welcome, David.
Thanks, John, for that information. Can everybody hear me okay? Sounds like the mic's working. Okay. Thanks for this invitation. This is kind of my first post-pandemic biggest in-person ground rounds that I've done. So excited to be here. I want to thank Stephanie, John's assistant, for all the work putting in the itinerary for the next couple of days of meeting people here. So excited about that. Personalized pediatrics, pharmacogenomics, it's our first step into precision health. I have some required Children's Minnesota disclaimers, and I have no financial disclosures for everybody. The objectives for this presentation are just to do a little bit of background of what pharmacogenomics is, how we can use it to adjust or improve medication use in pediatric patients. The bulk of the presentation will be going through our pharmacogenomics implementation at Children's Minnesota, and then hopefully there'll be some time to go through just a few cases to illustrate how we've been using the program at Children's. So a little bit of background. I think we're all aware that there are many factors that affect drug response. There are many things outside of us, extrinsic to ourselves, that may be controllable, and then there are intrinsic factors. And kind of the newest information that we can use is genetics. I think this is what makes precision health, precision medicine more approachable to us, being able to use genetics a priori in making medication decisions. And with the growth in bioinformatics, being able to crunch those numbers and get a lot of this data together is moving things forward within precision health. What is pharmacogenomics? Just real quickly, we have all used standard doses, whether it's like the standard 100 milligrams for an adult-sized patient, or even standard doses in pediatrics that are scaled to usually the body size, milligram per kilogram dosing. And when we do that, we know that because of the way medications are developed, most patients will respond as expected, and we get that desired response. But some patients will have no response, and some patients may have side effects, some of them dose limiting, or they may not be able to use that medication. So being able to insert some genetic testing into the process can do like ahead of time, make sure that the patients who are going to respond as expected can get that standard dose of the medication. Patients who might have side effects, we may give a smaller dose, adjust the dose, and then those patients who were not going to respond or were not likely to respond, we can pick a different medication altogether. Where that impact comes are in sort of the two phases of medication processes that result in our clinical outcomes. We have pharmacokinetics, what our body does to the drug, absorption, distribution, metabolism, excretion, and then pharmacodynamics, what the drug does to the body. We have drug targets, mechanism of action, leading to our drug response, and those together result in our outcomes of either drug efficacy or drug toxicity. What we look at for pharmacogenomics are genetic variants, usually germline genetic variants that are responsible for the drug metabolizing enzymes, drug transporters, and things involved with pharmacokinetics, and then genetic variants either in the receptors, unintended targets, signaling cascades, ion channels, and most of our information that we have right now is focused on the pharmacokinetic side of things, with many things being developed or highly researched in the pharmacodynamic or response side. So the criteria for as we started, we had to develop criteria for clinical implementation. As we begin to look at criteria for clinical implementation had to be developed. How are we going to do that? With that, we have to evaluate gene-drug pairs individually. And some of the criteria then that we need to have is that a genetic test has to be commercially available. We can't use a research test clinically outside of a research protocol. So to be able to do this clinically, there has to be a commercial test. There has to be a good genotype-phenotype relationship established in the medical evidence. And then evaluating what the severity of the clinical consequences are, how adverse are the adverse events or lack of response that the patient might be experiencing. And so we need peer-reviewed evidence to support a therapeutic action if we're going to do this preemptively as part of precision health. And so the two choices most of the time are to select alternative therapy or adjust our starting dose and dose titration. I can probably give an entire presentation on pharmacogenomic resources, but the ones that we use most commonly are from the U.S. Food and Drug Administration, information in the drug label. Like 3 years ago, when this was first updated by the FDA, there were about 150, 175 medications on it, and it has swelled over the last few years to close to 600 medications that have some sort of pharmacogenomic information in the drug labeling. And then within the pharmacogenomics community, PharmGKB, people are aware of that, is an online resource for pharmacogenomic information. They review the medical literature and annotate it and give sort of levels of evidence for information for the gene drug variants. And then CPIC, the Pharmacogenetics Implementation Consortium, has been creating guidelines, evidence-based guidelines that are published, freely available to clinicians that can be implemented pretty straightforward. All of this has started to come under the umbrella of what's now becoming called ClinPGX, and this is an effort to integrate pharmacogenomics, which has been sort of its own community, with the greater genetics community with interactions with ClinGen and ClinVar. And there's a pharmacogenomics working group within ClinGen that is working to standardize more nomenclature and more of the guidelines for how evidence is established for pharmacogenomics. So more to come on that. This is just announced earlier this year at the ClinPGX meeting, the first ClinPGX meeting. So what does pharmacogenomics give us then? It allows prescribers to individualize medication therapy. We can select between medications that are therapeutic equals that a patient may be more likely to respond to, adjust the dose of medications, hopefully minimize trial and error effect. We know that patients who trust their medications are more likely to be adherent. So if we can do anything to increase patients' trust of their medications, this is a step in that direction. In 2023, a large multi-country group in Europe published their evidence of a 30% decrease in adverse events with preemptive pharmacogenomics, and so within their practices. This was all in adults, of course, and so we need similar information for pediatrics. And so that's where a lot of our limitations of the study are. Our program and a lot of programs try to use multi-gene panels. All of the data are in single gene drug pairs, and so trying to justify data for these large panels it needs to be accomplished. And then the pediatric data, a lot of this data are in small pediatric populations. There are a lot of common barriers between adults and pediatrics that for pharmacogenomic implementation, including sometimes lengthy turnaround times for tests, complicated test results, with frontline clinicians needing help understanding or interpreting what these results are. PGX test panels are not standardized, and so you can have different genes, different variants interrogated on many of the genotyping assays that are out there. So a result from one assay may not be the same as a result from a second sort of similar assay. Our prescriber comfort in using pharmacogenomic results. Our EHR is not built to handle genetic data, as a lot of us are probably aware. PDFs cannot be used to develop, scanned in PDFs in the EHR cannot be used to develop any sort of clinical decision support. And so we need to have discrete data for each genetic result if we're going to build that. And our fragmented healthcare system doesn't help, along with reimbursement issues with from the insurance companies, the payers at this time, all are big barriers. Added to that, there's complexity of maturation with children. So we have the ontogeny, or the effects of maturation on the development of drug metabolizing enzymes and transporters, where we have, again, I said most of our data is right now. And this is just a simple graphic demonstrating that many of the biggest genes that we look at, the Cytochrome P450s, the individual family members come online at different times and at different rates throughout childhood. So needing to evaluate this complexity in pediatrics is also a challenge. So Children's Minnesota, we have two campuses. We are an independent pediatric healthcare system, largest in the upper Midwest. We have a campus in Minneapolis, and then the second campus in St. Paul, 429 staff beds, a little over 5,000 employees, 9 primary care clinics, 7 rehab sites, 9 specialty clinics. So we're not affiliated with any university. Many of our clinicians are adjunct faculty at the University of Minnesota, which is sort of between the Minneapolis and St. Paul campuses. And we do most of the pediatric training for the university in the pediatrics department. So when we began developing, when I was hired in 2016, there was the beginning, or I was beginning to look at implementation science, and was able to use some of the resources from CFER to develop a plan for our implementation. This is the plan that I used as I presented this to administration and the various groups within Children's Minnesota. There's a long pre-implementation phase where we get started, build our team, assess our readiness, and really begin our plan to implement. And then there's an iterative process within implementation where we implement and monitor and make improvements. You'll see the PDSA, plan, do, study, act, as a big part of that work to improve the initiative. And we're after 8 years of the program, moving sort of into the stabilization phase, I feel, where we're looking at automation, looking at hoping to scale up, hopefully with some changes that are expected next year with insurance payers, and then implementing our marketing plans and things like that. So hopefully being able to move into sort of that next phase. I don't have enough time to go into like each step as we go through, so I'm just going to highlight some of our tools that we used and some of the things that we used to address each of these steps in the implementation process. Begin with building our team. Our program is within our medical genetics and genomics program, But we felt since this was involved with medications, we had to have some relationship with pharmacy or the Pharmacy and Therapeutics Committee. So we developed what is called a subcommittee of the Pharmacy and Therapeutics Committee called our Pharmacogenomics Oversight Committee. And then with that, we reached out to various stakeholders throughout the institution to develop the oversight committee and develop our policies and procedures and processes, from molecular pathology, clinical molecular pathology labs, to the pharmacy itself, all of the stakeholder medical teams who are prescribing the medications that might be used. And importantly, our IT clinical applications group, because they were the group that really helped us take things from just a scanned PDF that went into the medical record to actually having discrete data that we could use to develop clinical decision support within our medical record, or EHR. We began with a professional staff survey, and we had a 15-question survey that we sent out to the professional staff. Just the biggest question that sort of exemplified our professional staff's response in 2016 is, I'm ready to use a pharmacogenomics report that a patient may bring to me, in the clinic. And 70% of our clinicians said they strongly disagreed or disagreed. The 3% of agreed were a couple of new graduates in the pharmacy. Our pharmacists are considered part of the professional staff at Children's Minnesota, and a few varying degrees. We have a lot of senior clinicians at Children's Minnesota, and pharmacogenomics is just not part of their training. So we had a lot of work that we established for that with respect to education. They did identify the need that we really needed to do extensive education for our professional staff. Our plan to implement, we had to identify the lab. There are some papers out there about how to identify reference labs looking for pharmacogenomics, develop indications for pharmacogenomic testing. We selected just a small group within our oncology group, the gene TPMT and 6MP, or 6-mercaptopurine, as our initial gene drug implementation. And so that sort of kept it local so that we did not break the system going across the entire health system with a much more frequently used medication. So with that, we had to develop the electronic clinical decision support with our IT colleagues, develop our how we're going to interpret each of the results for the use of the team, our point of care alerts, build and test all of this, provide pharmacist education, prescriber education, and as we expanded, design our care models for our ambulatory care and our inpatient groups. We began just with a simple spreadsheet to track this. This was our gene drug implementation checklist. We had a checklist for each step, looking at clinical and scientific evaluation, and then specific action items that we needed to do prior to go live, making sure that we added the gene to the EHR so that we could input the results, get our interpretive language. The spreadsheet has been replaced with, we now maintain a monograph for each gene drug implementation. We have a gene monograph, and then each drug has its own monograph. And all of these elements are now sections within that. So it's much easier to track our changes and things as we grew the program. Our EHR implementation then, our initial result entry to get these discrete results in was a manual process. Our IT people were able to build what we call the power form. And with 3 clicks, we could manually get a discrete result by clicking on the gene, clicking on the lab where it came from, and then a pre-built genotype. We also were, you can see other on that screen, we were able to put in a genotype that we had not pre-built. And then with the pre-built genes, you can see everything below that blue line was automated. So it assigned a diplotype, it put it, whether it was a normal result or an abnormal result at that time, and developed an interpretive consult that used standard language to interpret the result for someone looking at the result in the EHR. With that, it allowed us to build our clinical decision support, or CDS. CDS is important, but it can also be a burden on our clinicians if we have too many interruptive alerts. We're all concerned with alert fatigue. So we try to focus a lot on passive alerts as much as possible. This began with the result interpretation, trying to incorporate things into order sets and order sentences. Then our active results are pre-test to remind people to order testing for especially high-risk medications, and then post-test to guide therapy. And so working with our CDS oversight group and our IT group, thoughtful CDS implementation hopefully limits alert fatigue, and we'll look at some of our alerts coming up here. One thing is emphasized is that clinical decision support should not be used as an education tool for pharmacogenomics. When a clinician is busy trying to go through, popping up something that's meant more as education does become an alert fatigue type of an alert. We built within our Cerner EHR a landing page for results. This is our results page, and you can see we've got what we called abnormal results at the time, and then typical or standard results on the left-hand side. And then we're able to pull into this medications, the patient's home medication list, and if this patient were inpatient, that little green bar up there would contain all of their inpatient medications. And with that, we were able to highlight any gene-drug interactions that the patient was experiencing. So we were able to bold those, highlight them in red. And for this patient, they were a TPMT intermediate metabolizer. And if clicking on any one of these arrows will open up the interpretive consult. So this will tell a clinician, give them more information other than just the phenotype about the implications for the medication. It's a standard format, diplotype interpretation, phenotype assignment, and simple dosing recommendations. We're also eventually added personalized medication lists to this page, so we can look at significant gene-drug interactions in sort of a red section of the page, and then specific to that patient, as well as less significant or potentially less therapeutically less dangerous results in sort of that orange and it's supposed to be intended originally to be sort of a yellow section for those. So personalized med lists can be what we're incorporated into that. We also have some passive decision support when we don't fire alerts, being able to have important information just passively displayed alongside of the orders the clinician is putting the order in. And then also looking from the medication list, if clicking on that medication, we were able to passively display any important gene-drug interactions for that patient on the medication list display. The bane of a lot of clinicians' existence, the point of care alert. We have done a lot of work with these. We were able to fire alerts for specific gene-drug interactions that we thought were more likely to result in harm to the patient, something that they could get hospitalized for. And so we tried to limit the number of words on it. When you look at the CPIC recommendations for point of care alerts, they sort of read like novels. And we tried to keep any line less than like 15 words or less of information, highlighting important things in like bold and in red. Additional information could be found at the links that are found in the alerts, and then trying to incorporate other information that that might be helpful to the clinician, ordering pharmacokinetic levels if it's appropriate for the medication, ordering any sort of monitoring, things like that. We could incorporate orders for that into the alert to try to streamline the ordering process for the clinician. I think in the interest of time, I'm going to kind of go over some things a little bit more quickly. Basically, this is our standard workflow where you can see the workflow on the left with looking at the genetic results and how they're filtered. We get a lot of results that we don't use that are maintained outside of the EHR until we have sufficient evidence to use them. Then we can move them into the EHR, which are used to then trigger the clinical decision support. And on the purple diamonds on the right side are sort of the actions of the Pharmacogenomics Oversight Committee in overseeing how sort of that filter works, how the decision support is originally designed and then updated over time, and then ongoing. The last diamond is sort of our ongoing review of the CPIC guidelines, any new FDA information, so that we can continuously update our information here. Our clinic model, we have a 2-visit model that we use for pharmacogenomics. For our people who are referred to our clinic, we get a referral from either an internal or outside of children's referral. We have an initial visit. We order the genotyping, so we get the results. The results are posted in the EHR. Those are immediately available to the clinician to make any changes. And then we have a follow-up visit with the family to educate them about their results. And then we don't have a way to track this. We rely on the families to follow up, but we encourage them to follow up with us annually, update their reports, give them updated if there's any new drugs, new genes that we have added to their report. And then as our patients age out of the system, we are trying to develop sort of transitions of care, making the families aware that we can share this information with any new clinicians outside of children's or as they move into adult care. For our research side, there's just the results return visit. They get a limited amount of information during the consent process, but then the results return visit starts with a visit from our genetic counselor who provides a genetic education about the pharmacogenomics results and then follows a similar process. Our inpatient consults are similar. We have an electronic order that prescribers can place in the EHR. Pharmacogenomics pharmacist visits them in the room. We order the testing, and then typically, since patients, by the time we get the results back, they're typically outpatient. We have a follow-up patient visit in the clinic. So in that implementation and monitor stage, again, we have to do the gene drug pairs individually. We, like I said, opened our clinic, collect our CDS. I'm sorry, I meant to remove this slide since I already had kind of talked about all these previously. So we have 16 genes that we have implemented with over 40 medications that have some sort of decision support built into our EHR. All of our decision support is either based on FDA guidelines or CPIC guidelines. As I said, for kind of the preemptive type of dose adjustments. We'll look at genes without CPIC guidelines or drugs without CPIC guidelines, genes, things like that, where we have that information for specific consults on patients when indicated, and we'll consult on them as well outside of the sort of the standard CPIC and FDA recommendations. Moving on to our point of care alerts. We're working on getting our 2024 results. But our results from last year, we had 594 interruptive alerts that fired across 131 patients, 238 encounters. Our prescribers saw 368 of those alerts. Other healthcare team members, 226. The top 5 drug gene alerts, you can see there, omeprazole PPI was our #1 alert, and just that evaluation, this is made us concerned. We've done a lot of work to decrease the alerts for PPIs. They're not a critical med. The CPIC guidelines as they're designed kind of developed in we ended up creating an alert that like fired too much, and we've really adjusted that down for this year and have seen a decrease. And then within our oncology world, mercaptopurine is our second. And so we are able to dig into some of that information that we are evaluating. We have point of care alerts, we had 70 alerts that fired, 40% inpatient, 57% in our clinic, and 3% in the emergency department. And to pass through the alert, clinicians are asked to select options from a drop-down. And you can see here, some of them canceled the alert. There was one modify that they that was selected. Except the alert recommendation, you can see there were two of the alerts were that patient stable on current dose was the most common drop-down alert, and then a couple of other comments that the clinicians provided their reasoning for bypassing the alert. And so we are digging into this. We found that our clinicians are good at adjusting preemptively the dose of the 6 mercaptopurine. Recommendations are to actually try to titrate the dose back up with a preemptive dose decrease to make sure that we have appropriate immune suppression for these patients. And that we found on review of this is not happening as often. And so we're working with our oncology pharmacists to develop a pharmacist-led thiopurine monitoring service for these patients to ensure that we're optimizing therapy and actually trying to titrate the doses back up. Within our behavioral health group, we had a similar situation with these alerts firing more excessively than we needed, than they needed to be, and so you can see the highest rate is that patients are stable on their current dose. And so we have built some other factors within the alert firing to, if this patient stable on current dose has been selected, it will suppress the alert firing on future orders for that clinician. So that's something that we're trying to do as this year. We'll see how and the months coming up to this so far have indicated that that selection is being selected a lot less. So improving the alert firing there. So stabilization, some of the things that we're working on is kind of based on our antibiotic stewardship program. We've created a pharmacogenomics stewardship program where we run daily reports of new patients admitted to the system with who have pharmacogenomic alerts, and the pharmacist and the 2 pharmacogenomic pharmacists follow up with the teams following them to make sure that they understand implications for that patient. Again, our plans for scaling up, automating processes. We now have about 60% of our EHR results that are posted electronically, so we don't have that manual entry for the majority of our patients. We are developing self-referral and second opinion options for our clinic. I mentioned our thiopurine monitoring service for oncology, and we're beginning to look at expanding some of the CDS for other genetic conditions, such as patients with prolonged QTC with genetic reasons, for that. We've surveyed our parents and asking them after their appointments during the first 6 months, do they think their child benefited? Most of the patients said in the affirmative, and when asked why, you can see the reasons there. They understand why the patient, some of the meds they had may not have been effective. They got more information. They helped them advocate for their children. Why, for the patients that answered no, the results, not enough medications are included to benefit, but the one we saw most often after many trials and errors was the testing was offered too late. Should have been offered before they went on sort of this medication odyssey. So we had some other questions, but this is our patients. 100% of our patients did answer the question affirmatively that children with their condition should be pharmacogenomic testing should be offered to any patient with their child's condition. 100% of patients answered that question affirmatively. Looking into our research program, we have what we call preemptive PGX testing for our specialty patients. And so we are using a very large panel test that has 1,100 genes on it, and just casting sort of a wide net for these patients. And so these preemptive results are mainly in our oncology group, patients going to stem cell transplantation, patients with congenital heart defects and heart transplantation, and then patients who have experienced significant adverse events that have resulted in a hospitalization. It's an observational study. We are just evaluating right now exposure to medications with pharmacogenomic impact, describe the adverse events that are seen, and estimate the frequency of the actionable results within our population. We're almost to accrual. We're at 351 out of 400 planned patients within this study. Just a little bit of interim analysis that we've done so far. We've had quite a high frequency of use of many of the medications with CPIC guidelines, and you can see those there. Tricyclic antidepressants, pain medications, SSRIs. We were able, with pharmacogenomic testing, to preserve tramadol use within our population. For people who are aware, the FDA has recommended against tramadol use in children because of the interaction with CYP2D6. And so our group still uses that quite a bit, pretty effectively. And then voriconazole. Some of the adverse events that we've seen, unfortunately, 2 patients, before we got the results back, were given amitriptyline and had some CNS toxicity. We had one patient on dextromethorphan, a common cough syrup, that was admitted with CNS toxicity, very high concentrations, who ended up being a poor metabolizer, CYP2D6 poor metabolizer for dextromethorphan. You can see one ultra rapid metabolizer with CYP2D6 did have again, she got tramadol before we were able to get the results back, but did have significant toxicity with tramadol. And then quite a few of our intermediate and poor metabolizers report inadequate analgesia with tramadol. So those patients have moved to different pain medications. And then one patient with voriconazole had significantly elevated levels. They were a CYP2C9 poor metabolizer. All of this sort of giving us the, since all of these so far have occurred prior to getting the results back, even though the results were ordered, it's one of the reasons we're planning to bring testing in-house to decrease turnaround time and to be able to better focus on hopefully preventing these types of adverse events in the future. We have a second prospective protocol that is a multi-site study. Lucille Packard is part of the Stanford Children's Genomic Medicine Consortium, along with 9 other children's hospitals. And we have and so within the consortium, we were given some seed money to begin pharmacogenomics, or to promote pharmacogenomics implementation within member hospitals of the consortium. And I'm one of the co-PIs, and April Schultz at Stanford Health is the other PI. Right now we have participants from Banner Health, CHLA, Children's Minnesota, Nicholas, and Stanford Health. We've got testing available for 100 patients per site. Our protocol opened in just this March, and the primary aim is to evaluate the acceptance of the CPIC guidelines for patients receiving SSRIs. for that. So we've enrolled 9 patients so far at Children's Minnesota, and right now that's where we're at. So we have some other research going on. Within our EHR now, we have just under 2,000 patients who have pharmacogenomic results as discrete results in our EHR. We have some retrospective studies that we're conducting with some pharmacy students that are interested in this, with looking at the atomoxetine and CYP2D6, fluoxetine, and CYP2D6, CYP2C9. We are also looking at, with our larger panel that we get, we're comparing HLA genotypes that are obtained through an imputation algorithm using tag SNPs, and comparing that to deep sequencing for our patients that are going to bone marrow transplant, and looking at the accuracy of the imputation sort of estimation versus the deep sequencing. We have just completed, and it's impressed, an observational evaluation of pharmacogenomic testing in our sickle cell population, evaluation of our pharmacogenomic stewardship program as an educational tool for prescribers, and just recently got a small in-house grant to look at the HLA haplotypes in our patients who experience hypersensitivity reactions to asparaginase products within our oncology groups. So I'm looking at just a few patient cases that we've had come through. Early on, this is one of the first patients that I was consulted on, was a 18-year-old male with high-risk T-cell ALL, and had been tested for TPMT after a hospitalization with fever and neutropenia. This came back normal, and he continued to experience toxicity with his 6MP, and had 3 additional hospitalizations with fever and neutropenia. At the time, NUT-T15 was not well known. This was something I suggested testing, and luckily for me, he came back as an intermediate metabolizer for NUT-T15. By this time, we had already adjusted his dose down, and he had been on a stable dose, but at least we were able to explain it. And with that change, they had been reserving any TPMT testing at the time for patients who had experienced toxicity. We now test all of our patients who are expected to receive 6MP prior to receiving it, so we're able to make those implementations ahead of time. Just this January, we had a 12-year-old boy who, from northern Minnesota, who came into the St. Paul ED in acute distress with fever, increased heart rate, nausea, vomiting, psychotic symptoms, hallucinations. And his diagnosis was a reaction to the medication benzaprine, which he had received about 6 hours earlier. He was admitted for observation, and it took a 3-day hospitalization before these symptoms resolved. And during that time, he was referred to the pharmacogenomics service. This was a young man with ADHD, autism spectrum disorder, and a history of self-injury, who was threatening to hurt himself at home. He was brought to our inpatient unit, where he was stabilized. His antidepressant medication was discontinued. He was started on the medication aripiprazole or Abilify, which is a second generation antipsychotic agent. He calmed down after a few days, and because he was inpatient, his dose was very quickly titrated up, and then he was discharged. On the day of discharge that evening, he reported to his family they were starting to feel shaky. And in the evening, his parents reported that his shoulder felt like it's in his neck, was what he told his parents. And by that night, he had developed torticollis, a dystonic reaction attributed to the Abilify. He was brought to his local emergency department, where they gave him the standard treatment for that benztropine, and he had very quick improvement of his symptoms and was discharged home. But then he became more disoriented, flushed, felt hot, and increasingly confused at home. And so his parents loaded him in the car and drove him to the St. Paul ED for follow-up. After referral to our service, we found two pharmacogenomic findings for him. He was a poor metabolizer for the aripiprazole and an intermediate metabolizer for the benztropine. The benztropine he was just under the weight for a typical adult dose, but they gave him the full adult dose because of the severity of his symptoms. And so it's likely that he experienced two separate adverse events that could have been prevented with pharmacogenomic testing. And then lastly, another one of my very early patients was a 15-year-old male on an 8-year odyssey of trial and error with medications for her depression, mood dysregulation. She had several suicide attempts, had been multiple hospitalizations with her generalized anxiety disorder. At least 12 medications I was able to identify in the record were not able to either relieve her symptoms or cause unacceptable side effects. Pharmacogenomic testing for her found her to be CYP2C19 poor metabolizer, CYP2D6 poor metabolizer. These are two very important drug metabolizing enzymes for many of the SSRIs, SNRIs, and a CYP2B6 intermediate metabolizer. She was started on a new medication that avoided any of the CYP interactions, and almost immediately improved. She actually was able to go back to school full time, and many of her supportive medications were able to be weaned off. And so this was a very early win for us within the pharmacogenomics team here. In wrapping up, what's next for us? As I mentioned, we're bringing testing in-house for our patients. We're developing self-referral and second opinion clinics. With the use of the consortium study, we're actually able to expand a lot to our primary care, who we have not been able to get as interested in pharmacogenomic testing as our psych and our oncology groups. And so primary care is beginning to do some referrals for our protocol. Unfortunately, all of this customization that we've built will in 2 years be sunset as we move from Cerner to Epic. And so looking at what Epic has to offer and learning from what we've done. So hopefully our Epic implementation will work better than Cerner. Looking forward to that because I think Epic has some exciting things with their genomic indicators. And within our precision medicine program, pharmacogenomics is just the first step. I think Epic is going to allow us to use expansion of more AI and the ability to use their multi-omics to increase our implementation of precision health. I have to thank everybody who has been involved with us over the last 8 years, and many consultants or collaborators from the University of Minnesota, our IT group, our professional staff champions, and mostly our pharmacogenomics team. Günther Scher was our original geneticist who hired me to begin this program. We have a second pharmacist who works with me now, and an assistant who has the unfortunate job of entering any of our manually entered results when they come in, and working very closely with our genetic counselors to ensure that our patients are getting the overall genetic care as well as their pharmacogenomics care. And with that, I'm happy to take any questions. And I've got my email there for if anyone has any.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.